Welcome to CardioVisual. My name is Tom Blevins with Texas Diabetes and Endocrinology in Austin, Texas. Today, we'll be talking about SGLT2s and the increasing need for endocrinologists and cardiologists to work together in managing our patients with diabetes. Well, Bob, let me ask you another question. That is, currently very few of the scripts written for SGLT2 inhibitors are initiated or written by cardiologists. How do you think we might change that?
You want to get prescriptions for cardiologists, they have to understand the mechanism.
Right.
They're scared of this drug in some respects because, you know, first of all, it works on the kidney. That doesn't bother endocrinologists. That's all right. But to the cardiology guy, that's not usual. Then you guys add to it, well, you know, it loses calories. And then, well, then we have a potential upregulation of ketones, a little ketogenesis. That makes them a little bit nervous. But the beauty of it is, it's just one pill, 10 milligrams most of the time. That's it. Now, depending on which drug it is, but you don't even have to worry too much about it. But the cardiology guys, 6% of the market is written by cardiologists. Even though in the cath lab where I work, I recommend this every single day to most patients that have low EFs. And it's still, well, Bob, don't you think we just use Lasix? Well, these trials were already taking Lasix, some of these patients. It still did better. It works in just a few days, you know? What do you have to lose? Well, they may get hypoglycemic. They're scared of the hypoglycemia part. Even though you explain if they're not taking insulin or SUs, don't worry so much. And send them back to the endocrine guy. Let him take and manage them further. But just starting it, we cath, a couple thousand people a year. You know, if they would just simply, diabetes patient or a person with a low ejection fraction, just give them the pill or recommend it in your notes, you know, if you're afraid to use it. But I think they will use it. It's probably just as safe as using a statin, just as easy. You're used to these kind of drugs. See, you're more basic science based than we are. Ours is a little bit more stent based.
Do you think there's one particular mechanism by which SGLT2s reduce cardiovascular events or reduce heart failure? Do you think that they affect atherosclerosis directly, or is it just an indirect effect?
Well, SGLT2s are like the PPARs, Tom. They hit everything. If you look at all the areas, I remember one time Jorge Plusky put up a slide and says, where do they work? And he pushed the button and there was everywhere. It was hitting everything. Well, the SGLT2s are doing similar things. Let me give you an example. I've always been interested in what is the mechanism of vasodilating from an SGLT2. And the common response is it increases nitric oxide. Well, if you give nitric oxide blocker L-name, it still works, even though you knocked out nitric oxide. Well, then it must be a calcium channel blocker. So you give a calcium channel blocker, knock it out, it still vasodilates. And then you get into it and you find out that it works off of V2 receptor, which is a potassium channel. And then you say, well, gosh, that's really remote, probably totally uninteresting for a cardiologist for sure. But then you look up and you find out the potassium channel blockers relate to drugs like amiodarone. Then you go, a lot of cardiac deaths there in the one EMPA-REG trial. I wonder if it's an antiarrhythmic, you know? I mean, there's no proof of it, but it gives you an idea of the tremendous breadth of an SGLT2. Or you could say it's the tremendous effect throughout the body of how important insulin and glucose is. Glucose goes everywhere. It's a marker. If you raise it too high, you've got a problem because you're probably producing too, maybe you got too much of an insulin blockade, or, you know, a person is just even hypercoagulable. High glucose levels are not your friend, especially in real high levels. So I think, again, you're moving outside of the cardiology box, but it's very much, it affects inflammation, the inflammasome. It hits the coagulation profile, it hits the blood pressure. It's an amazing compound when you think about everything it does. And get rid of what, 12 tablespoons of salt a day? Not bad for a drug that lowers the glucose to about, 1%, But it doesn't lower it, as I understand, in people that are normal. It may bring the threshold down, but it's not going to really change your glucose level circulating. But you still will lose calories, 400 calories, 2 cans of Coke. Not bad for a drug that you just give for that. I mean, there's just some neat little overtones of a drug that came off of the apple tree from just a crazy apple tree bark is all it is.